If you break down the word rhabdomyolysis, it means rod-like muscle and splitting. The rod-like muscle refers to striated skeletal muscle, which looks like long rods on microscopy. So when you put it all together, it literally means the breakdown of skeletal muscle. This makes perfect sense because rhabdomyolysis is just a syndrome characterized by muscle necrosis, causing the release of intracellular constituents into the circulation. Accordingly, the etiology of rhabdo is really intuitive. Anything that causes injury to the muscles can result in this syndrome. You should consider things like drugs, for example amphetamines and salicylates, overexertional states like seizures and neuroleptic malignant syndrome, trauma, which is usually from falls or long lies, and I always add on statins because it's a really common drug that often is associated with rhabdo. This also makes a cute little acronym, DOTS. Now, to understand why you get these clinical features of rhabdomyolysis, you need to understand what's inside a myocyte and what these components do to the body if you suddenly release them. Myocytes, like other cells, have high levels of certain electrolytes like potassium and phosphate. However, they're unique in that they utilize myoglobin for oxygen delivery. Moreover, they have high concentrations of creatine kinase, which is essential for cellular energy metabolism. Let's focus on myoglobin for a second. This protein is a close cousin of hemoglobin and has a protein or globin component and a heme component. Most of the issues from rhabdo come from this second pigmented constituent. In the kidneys, myoglobin is filtered by the glomerulus into the urinary space where heme pigment is released. This causes acute kidney injuries in 3 ways. Firstly, heme can build up and cause tubular outflow obstruction. Secondly, it's cytotoxic, which can directly induce tubular epithelial cell injury. Finally, it induces vasoconstriction, which results in renal hypoperfusion. With this in mind, let's think about the clinical features of rhabdomyolysis. Some common general symptoms include malaise, myalgia, and weakness. As I mentioned before, the patient might have hyperkalemia from the muscle lysis, but also from the AKI. This should make you think about cardiac manifestations, like conduction abnormalities causing bradyarrhythmias, and features like ascending muscle weakness. Now, one thing to remember is that hyperphosphatemia can cause hypocalcemia. This is because phosphate loves to bind to calcium, which can be a problem when there's lots of it. Hypocalcemia should make you consider spasm features, like spasms, which can be seen when you're looking for Chafsteck's sign and Trousseau's sign, paresthesias, especially perioral ones, anxiety, seizures, muscle hypertonia. Because of the toxic myoglobin, the patient probably has an acute kidney injury, so you would expect low urine output that is concentrated. Importantly, myoglobin urea classically looks like brown, dark urine and is sometimes described as being tea-colored or Coca-Cola colored. Let's move on to the investigation of rhabdomyolysis. I always like to have a structured approach and consider bedside tests, bloods, and then imaging. The first bedside investigation to consider is an ECG. This should highlight features of hyperkalemia, like tented T waves. Perform a urine dipstick. Remember, there shouldn't be any hemoglobin and red cells in the urine, but myoglobin. Sometimes this can cause misleading results depending on what type of dipstick you do. Since you've got a urine sample, you might as well also send it off for a formal MCS. The first blood test to consider in the emergency department is a VBG, so you can quickly see their pH and their electrolytes. Consider other typical bloods like a full blood count, a UEC, LFTs, and don't forget a CMP. Think about doing blood cultures if there are any septic features. The most specific test or diagnostic test you can use for rhabdomyolysis is creatine kinase levels. These levels have been shown to correlate with severity, and you should expect a CK level of more than 5 times higher than the upper limit of normal. Imaging is probably not necessary unless there's a good indication. For example, imagine an old person who's had a fall. Consider doing a CT brain. For the management of rhabdo, you just need to think about an AKI with some additional considerations. There's a great mnemonic for the management of AKIs, which is STOPPED. S is for sepsis because you should always think about sepsis as a contributing or etiological cause. T is for toxins because you want to cease any drugs that are going to make the AKI worse, like NSAIDs. O is for outputs and inputs. You want to monitor urine output and also give fluids. Really, the mainstay of therapy for rhabdo is aggressive rehydration to promote renal clearance of released intramuscular toxins. One of my clinical supervisors always used to say that the solution to pollution is dilution. Both P's stand for potassium. Hyperkalemia is extremely important to manage early and as a priority, which is why you get 2 letters for it. There are 3 steps to managing hyperkalemia. Firstly, cardiac membrane stabilization using calcium gluconate. Secondly, shifting potassium into cells using insulin and dextrose. Finally, eliminating the potassium definitively by using potassium binders like rosonium. E stands for other electrolytes. In the context of rhabdo, consider using phosphate binders and calcium replacement. Finally, D stands for dialysis, but only if necessary. Let's summarize everything by putting our mnemonics together. Rhabdo is caused by DOTS, it presents with suck spasms, and must be stopped. DOTS is our acronym for the causes of rhabdo, including drugs, overexertional states, trauma, and statins. Sucks means serum 5 times higher creatinine kinase than normal, and spasms, which are features of hypocalcemia. Finally, stopped tells us to manage sepsis first, stop any toxic medications, output and input monitoring, potassium management, electrolyte management, and considering dialysis if necessary. Thank you so much for watching Townsend Teachings. Don't forget to like, comment, and subscribe.